Yes, welcome.
For you. Okay, I think we are ready to go.
Okay, let me move this away so that the cloud picture. Right, we'll give Andreas another minute to join us and then we'll start. Yeah, hello. Okay, you know what? We'll get started with our speakers. Hey everyone, welcome. I'm happy to introduce our speaker today, Professor Rashidi. She's at the University of Florida, where she, in addition to being a professor, also is the founder and co-director of ICute, which is the Intelligent Clinical Care Center. That means she works on applying machine learning and AI techniques to all things medical. She got her PhD from Washington State University, which is out in Pullman. After that, a short stint in Florida. Then she went off to become an assistant professor at Northwestern. But the pull of Florida was strong, so she came back there just a year later, and she's been there since then. I was looking at her CV. Her list of awards runs pretty long, so if I start telling you about all of them, I'll take up too much time. Let me just say that they span a good decade and a half, starting with the Best Dissertation Award at her university, to an NIH Trailblazer somewhere in the middle, to most recently a fellow of the American Institute of Medicine and Biological Engineering. I think that's what it is. Anyway, so without further ado, Professor Rashidi.
Thank you very much. Yeah, glad to be here and to have a chance to talk about some of the work that we have been doing in the ICU using medical AI. So I will be talking about different projects today that we have been working on in the past couple of years. And here you can see what roughly I will be speaking about, what we call as AI augmented patient monitoring. And especially in the acute care setting, which is the ICU setting and also perioperative setting in the OR room. I'll talk about clinical trajectory, how we can monitor the trajectory of patients, how they are doing, a little bit about how we can use computer vision in the ICU in order to track some of the clinical indices. And then I'll talk about, besides the physical functions, those visual cues and the physiological monitoring, what else we can do? Cognitive function monitoring is another one that is becoming important, especially in preoperative setting that I'll talk about. And then briefly, if we have time, I will talk about some of the tools that we have been developing for medical AI, training the next generation, and then hopefully I will take questions from you if you have any questions. All right, this is the one slide that I usually start my presentations with. I update that every year, depending on what I perceive has been the dominating technology of that year. And I like it because it kind of gives us a view of how long we have come in terms of what we call as AI. At some point, we called it ML, at some point, big data, all of these names, and we are coming back all full circle to AI. And you can see just from 1942 all the way, very, very simple, just conceptual model. Now we are here with trillion parameter models, billion parameter models. 2024, I have left it still as a question mark. We almost have some ideas what is the major theme. It has been a lot of multi-agent systems and inference time computing, but we'll see what will be the major theme of 2024 once I update that in December. Now, beyond the general AI domain in different sectors, in healthcare, we also have seen a lot of development of AI, and not just in terms of theory and just developing a method and then applying that to a small data set, but also we are seeing a lot of interest beyond even the academic circle in terms of translating some of the models and methods. And if you look up the FDA approval for medical AI, models and algorithms, you will see a long list these days. A lot of that in the oncology, radiology space, but also in some of the other space, you will see that. So there are a lot of areas that we can use AI for. Here you can see some of those: diagnosis, personalized medicine, drug development. The list goes. Now, in terms of in my lab, what we have been working on, as I mentioned, we have been working a lot on what we call as AI augmented patient monitoring, especially in the ICU and also in the perioperative settings. Different aspects. For example, as I mentioned before, we can look at the physiology of patients to see what is their trajectory like. Are they getting better or not? We can look at their facial cues to track pain-related cues. Are they in pain? Many patients in the ICU, they cannot talk. They cannot tell you what is their pain score. So how do you adjust their medication? Physical function. That's very important to track in the hospital, and especially in the ICU, because if you can take just a couple of small steps in the ICU, it actually means that you are very close to recovery. But for some people, even if they can sit upright compared to yesterday, that also means that the recovery is closer than yesterday. So that's also another major index that clinically people try to track. And also, talking about the ICU room, what is going on in the ICU? If you have gone to any ICU room, there's a lot of noise going on. Sometimes people come in the middle of the night, they visit the patients, do some procedure. Patients don't get enough sleep. So that's also important to track. So there are a lot of different aspects of patient care in the ICU, in the acute care setting in general, that we would like to better monitor using the tools that we have. And I'll talk about some of those. We might not have time to go over all of them, but happy to discuss it afterwards if anyone is interested. And beyond the individual research lab that I have, at the center also, the Intelligent Clinical Care Center, initially, actually the name is not changed here, it's Critical Care Center. Initially it was smaller, then we expanded that to encompass more areas. And so now we have a lot of members. We call it Intelligent Clinical Care Center. We have a couple of different missions, research, of course, enabling the faculty, especially the early faculty. We have a number of pilot grants that we provide to them in different areas, almost all of them in medical AI. We have hackathons and datathons, an AI for healthcare conference that we hold annually in Orlando. If you are interested at some point, maybe some of you will join us. So a lot of activity is also happening at the center that sits between College of Engineering and College of Medicine, and my co-director, Dr. Aja Biarag, she is a clinician, and with me as a computer scientist by training. I think that's a good match, and I think that is the kind of match and collaboration that you would like to see anytime you have interdisciplinary work. All right, now let's start by this question: how's the patient doing? And that might seem like a simple question, but if you go to an ICU room and you ask the doctor, how's the patient doing? Can you summarize that in one number for me? That sounds like simple, but can we do that actually? In the ICU, where you have critically ill patients that might have multiple organ dysfunctions, it's actually very complex to give you that number. And that has been kind of like the holy grail of critical care. How do I give you a number that tells you how's that specific patient is doing and how's the patient in the next room is doing? And this is not something new. Actually, in clinical practice, people have been using different types of clinical scores that they have come up with to measure acuity of patients. One of those is called SOFA score that is routinely being used, the sequential organ failure assessment. You look at a number of different assessments throughout the day and pick the worst measurement, and it looks at 6 different organ systems. For example, for blood pressure, the nurse measures that throughout the day, picks the worst measurement of the day, and then based on that, computes the SOFA score. It's done once a day. The same with Apache score. The problem with all of those is that those are static. based on just a single data point throughout the day. They do not use all the data, and also they are not continuous. So in one of our early studies, and when I say early studies, it's 2019, the transformers are becoming popular. We developed this model to utilize basically all the data that we have in the ICU, and not just a single worst measurement. It kind of makes sense to use all the data that you have that is coming through all of these ICU monitors. Why throw them away? And develop a new version of SOFA score. So we developed that, and in fact, it worked really well. I don't have a pointer here, but I will use my hand. So what is here, this gray line, that represents the clinical SOFA score for a patient that passed away. They were in the ICU for 124 hours or so, and the gray line tells you what is the risk of passing away at the end. Clinical SOFA score tells you, no, the patient is doing fine. But if you look at the blue line, that's basically the model that we had developed and validated. It tells you, no, actually the patient, even from the beginning, we can tell you that there is a high chance of mortality. And this is something, here you can see how it works in real time. And we validated that internally and also externally. And this is, again, the case that even this example that you see here is from one patient, but it was validated on over 70,000 patients. But even if you can save a couple of patients' lives or do sooner intervention, it would be great. Now, going from the self-attention models in 2019 all the way fast forward to these days, we have been developing a lot of new models, just like everyone else, trying to see what would work better, how we can make those models work better. And one of the models that most recently we have been developing is a model based on Mamba blocks that you might have worked with them. Those are state space models, more specifically selective state space models that you can use. And we have found it actually to be working really well in the clinical setting. And I will show you some of the statistics for that. And we developed these models, again, comprehensively, because that's very important. You really want for those models to be evaluated internally at your own institution, externally at other institutions, temporally, and also prospectively. We have developed a real-time systems that captures the electronic health record data at UF. And not many institutions have that. Johns Hopkins also has that, but not many across the US have developed that kind of capability. And then we run those models and we provide the predictions in real time. Now, state space models, we chose that for this particular project because it was interesting from the perspective of the inference time and also the computational time that it is working better compared to the transformer models that have the complexity that sometimes cannot be scaled very well. And then if you also compare them to something like RNNs that have a lot of problems, for example, the limited long-range dependencies that they cannot handle. And state space models kind of like in the sweet spot in between. And we wanted to try them in a clinical setting to see how well they work on actual problems. And once we tested them, we found out that actually they are quite faster compared to something like the transformers. It's not like it's double faster. No, it doesn't scale linearly, at least for our problems. But I would say it is faster in the sense that maybe 1/4 faster, 25% faster. And that can be important for future applications when you are trying to run a model locally or on the edge device, or you want really fast inference time. That can be important. So just some interesting observations there. And it also is working really well in terms of the evaluation, at least again, in terms of the data sets that we have tested, the results are quite good. And For this project, we were looking at a number of different outcomes that you can see here. For example, whether the patient can be discharged, whether they are stable, unstable, whether they would need any life-sustaining therapies, such as mechanical ventilation. They would need something like this CRRT or vasopressors. Those are all important decisions that the providers need to know in advance in order to make interventions.
I have a very practical question, which
Yes.
pervasive in what you're doing, which is really pretty impressive. You are taking data from 54 different hospitals and real-time data. Presumably, you've solved all the privacy and medical record issues to be able to use its data.
Very good question. So this data on itself is de-identified in the sense that we are taking all of the HIPAA identifiers, except for age. And if you have age, even we run that through our honest broker. And then some of these data sets, for example, MEMEC is publicly available after you get training. So some of those are publicly available, but our own data set, we have had to run it on our own servers like 3 or 4 years ago, but we didn't have the high performance computing center that was not HIPAA compliant. But nowadays we have the hypergator that is HIPAA compliant, so we pass it through there. But still, you're absolutely right. We had to go through many loop samples just to make sure that everything is HIPAA compliant and we are adhering to all of the security requirements. All right, so we have done, yes, again, the evaluation just to make sure that the models are robust. And I'm not going to go through this. It just depicts how it would be different between a discharged patient versus a diseased patient and how that can be used for early intervention.
And so I have also another technical question.
Yeah.
So, for example, all of this data, you're looking at time series. I'm more interested in the real-time modified, which is the time series.
Yes.
And what you show there is you are really processing time series data from 100 sensors, or 100 instruments, or 100 observed patients.
I wouldn't say that the time series data in the sense of like having the vital signs is probably from, in case of ICU, is probably 7 different sources. In case of intraoperative setting, just the source of the data, it would be a little bit more because you might have like intracranial monitoring.
Okay.
But the number of variables that you get from also electronic health record, like the medication, the procedures, all of that is a lot of different fields. That is a mix of structured data with time series data. And also, yes. So you have a lot of missing data. You have a lot of different types of modalities, and then add to that also clinical notes. Here in this project, we did not incorporate clinical notes, again, because of privacy, because the identifying clinical notes, the identification has been considered more or less kind of like a solved problem to some extent, but still in medical domain, a lot of like institutions are holding off to that a little bit, because even if you have one piece of identifying information that might be in form of contextual information, that could mean a lot of privacy issues for the institution itself. So sometimes it can be quite difficult, but we already have the clinical notes for UF, and we are right now incorporating all of those into our models. Now, this one was a little bit different. So we said, okay, we have been using transformers and Mamba models, and everybody's using LLM. So why not jump on the bandwagon and also try to use LLMs? But there was one problem. The input to LLMs in most basic form is text data, natural language data. Here, as we were just discussing, we have other forms of data. So we have electronic health record data that is in a table format, and then you have time series data. So what do we do? But the LLMs, on the other hand, they contain a lot of knowledge, especially the clinical LLMs that have been developed. They don't incorporate EHR data, but they have been trained on the articles, clinical guidelines. So they know a lot about the conditions, but they don't incorporate patient data. So how do we get these two together to get a model that has the clinical knowledge from the public sources, but also can incorporate patient data, which is in a semi-structured, structured type of form. So we took a couple of clinical models that were available and also non-clinical model, Llama 3, when we started this project, 3.1 is out now. And we use some of the approaches that has been proposed in the literature before for converting table data into text data. We played a lot with different types of data, and because of the some of the limitations that we had with those models, the one that we were using, Gatortron, that had the best performance, has a context window of 500 something, which is quite small if you think about that these days. We had to make sure that constraint is taken into account. But anyhow, we converted the data, we are fine-tuning that, and then you have an LLM that has all the knowledge about PubMed, articles related, for example, to delirium. At the same time, it can use patient data. You give it a patient record, and then it can tell you about that patient. And then we also added one classification layer at the very end, and we trained that to our outcomes that we had labeled. So now the LLM can also do the prediction based on patient data that has been using and also based on the articles. Yes.
So for that, for PubMed, do you look at abstracts or do you look at the entire document?
So it was based on abstracts. So we did not retrain that part because Gatortron, for example, and Meditron, they have been training based on the abstract. But I think in the future, if it's full text, but full text is not always available, so that sometimes becomes a problem. Again, the results are good, not surprisingly, because now you are adding the external knowledge, just not patient records, and that makes it work better. I'm not going to go through this one. This is a similar problem, but for delirium. Again, the results, we see consistent results in terms of internal, external, also prospective validation. We are now in the process of prospective validation that is ongoing. So we are seeing new patients. We are evaluating on their results, again, for sake of robustness. And also it makes it a little bit easier to provide explainability and interpretability. But I guess that as the LLM sizes are also growing, that makes it also harder sometimes to also do the evaluation. But we see some new methods that can be helpful for LLMs these days as well. All right, so that was a very quick overview of what we have done in terms of looking at the physiological data, the clinical data of the patient that already is collected in the ICU. Then we thought about, okay, but what is in the ICU that we are not capturing? Is there more that we are not capturing? Can we collect more data? What are we missing? And in reality, yes, there is a lot that is not in the electronic health record, or is there very infrequently, or is not assessed in the all institutions. For example, physical function. As I told you before, it's very important indicator of recovery in the ICU, but how it's being assessed. The nurse has to go into the ICU room of each patient. They have a checklist for mobility index that says, can the patient sit upright? Can they do this? Can they take a step, one step, two step? It takes about like 10 minutes to do the observation, come up with a score, and then enter that into EHR system. Okay. They have to do that also for pain, because most ICU patients, they cannot tell you what is their pain level. So they have very specific scales. They look at certain facial muscles. We call them as facial action units. This muscle here, this muscle here. Do they see those specific muscles being activated? Okay, no, then add it up. That gives you a score. Again, that's not very easy because it's manual. It takes a lot of time in the ICU. It's also subjective, depending on who is being observed, who is observing them. And there are lots of studies, interesting studies, depending on whether it's female, male, different types of combinations, different ages. There is so much variability in human pain assessment. And it doesn't happen all the time. The nurse comes into the room, they observe you for 5 minutes, 10 minutes, then they have to go to the next patient. So you're not being observed for the next 4 hours. What happens to you in the next 4 hours? What if you don't show signs of pain and the nurse is there, but as soon as they leave, again, you're in pain. So all of those information are not captured at all, or sometimes manually. And then there are also other factors. Delirium is a condition in the ICU. And we think that most of the time it happens because your circadian rhythm, your wake and sleep cycle is disrupted. Why? Well, if you have been to ICU, there's always those devices, beep, 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 going on all the time, going off all the time. Then you have the people coming in the middle of the night, billing you for taking you to do imaging because that's the only slot that they had, or maybe that was more convenient. So there's all these disruptions. And for somebody who is critically ill, then we don't let them sleep. And we are not measuring this at all. How fragmented is their sleep? So all these kind of things that we could measure, but we are not even right now able to characterize those. So we said that, well, for a lot of those, you can actually use computer vision or sensor technology in order to capture some of those information. For example, excessive visitations. Well, if you have a camera in the room, you should be able to get that kind of information and see what percentage of that happens throughout the night, what percentage of that is happening throughout the day. And we have done that. So in a system that we have implemented in all of the ICUs at University of Florida, here you can see the scheme of that. Here is the actual ICU room. Those are actually students. We can now show you patients. We have 2 different camera systems, depth camera and also RGB camera. The RGB camera is zoomed on patient face, of course, for just privacy reasons, for detecting facial expressions. And the depth camera is taking the activity in the room, physical activity. Are they able to take 1 step, 2 steps, maybe sit up, run? They also have wearable sensors. We also have IoT sensors in the room for capturing light level, what is the sound pressure level, all of this information. So it's a lot of data. And so far, that number actually has to be updated. I forgot to update that. Right now, it's 362 patients that we have recruited. We collect data from each patient up to 7 days, 24 hours. A lot of data. Actually, we store our data, the archives on tapes. You wouldn't believe it because we have so much data. And this is the system. And this is what I tell my students, that it's not all about AI machine learning at the very end. It's about the infrastructure that you are developing before you get to that point. Once you have that infrastructure, then you can do a lot of interesting things. But before that, you need the infrastructure. So we have a local system that stays in the ICU room for capturing data, compressing everything, encrypting everything. And we are capturing a lot of different things. So we want to make sure that we are able to do some processing as well as do also the data capture. Then it goes to our high performance HIPAA compliant servers that does all the pre-processing. And it also is getting synchronized with the data that is coming in from Epic, which is our electronic health record system. Which for those of you, if you know anything about Epic, that part is also very difficult. It's just one arrow here, but it's very difficult to get that to work. And then we have also different interfaces, for example, for annotation, which was huge in our work. It's very difficult to do annotations on healthcare data. And I will talk a little bit about that. We have also interfaces for the healthcare providers in the room, so they can stop the system if they want. They can delete some portions of the recorded data, and so on and so forth. And here you can see, for example, some samples of the data. We are developing a lot of different computer vision models. I'm not going to talk about all of them. For example, for tracking, you need to be able to track the patients in the ICU room. You also need to be able to detect their activities, what they are doing. And again, the activities, initially we started with RGB cameras that gives you a lot of information like that. But then for privacy reason, although you were blurring their faces, still for privacy of the identification, we moved on entirely to depth camera, which has certain also limitations in terms of giving you rich information. But I would say that the biggest challenge for us has been the data annotation. If you have any other source of data set that is not sensitive, you can maybe recruit people on the web and ask them, hey, just like ImageNet, how it was done. It was done online, people annotating the data set. What about our data set? We have to annotate each facial landmark for pain and agitation. There was nothing like this when we started this in the wild. Everything else that has been collected so far has been in the lab, which is very different. And we were using some of the tools that existed, the models. They don't work on ICU data. They were giving us very bad performance. So annotate our data, all of these facial landmarks. We have to train each one of the annotators for 3 months. We have to evaluate them, make sure that they can do this. There is actually a handbook of facial action unit detection that they have to read. The same for mobility activity detections. We have developed like standard procedures for each one of those, how they can even annotate those. We develop our own annotation tools. And that's, again, all of the infrastructure that you have to build in order to build the data set that later you will use for building your model. So it's a lot of work before you get to that point. And you realize that when you're collecting 7 days, 24/7 data, okay, which one of the data frames you give to your annotators? You cannot give them all of the data. It's millions and millions and millions of frames. So which one do you select? Our solution has been to use active learning, which we have found to be very helpful. And now it's deployed and we are running that in real time. So our model is running in the background. And the ones that it's not very confident about, and the ones that we don't have many samples of those, in other words, as low density in terms of the number of data points, those are being selected, sent to the annotators for the next round of annotation. And we do this again, and we do this again, so the performance is increased. And that's how we address the whole annotation problem to be able to go around a challenging annotation problem. Again, this is the largest data set that has been collected so far. There is nothing like this that has been collected in the ICU. All of the other data sets have been collected in the controlled settings. And here you can see that working on not the patient, but my student, all of these AUs that you see here, those are the AUs that are related with pain and agitation in the clinical setting. And so you can see how in real time he's trying to make some faces and somehow painful faces, and you can see that. And we have seen this, also validated this on patient faces in the ICU. We compare it against the clinical scores for pain that has been done by the nurses, as well as the annotator ground truth that we are getting. But then the question was, okay, well, what if you want to share such a data set? Well, unfortunately, we cannot share the patient faces data set. So we have done all of that, but what can we do? And the answer was, what if we use generation? And we have been working on this for some time, and this is still a project that is ongoing, that based on the data that we have collected, we are trying to generate faces that we can control each one of their facial action units. So you provide the constraints in natural language. And for example, you can say AU12, which is the lip corner puller, or AU25, lips part here, and then it will be able to generate that. This is a model that we developed from scratch, and even the architecture, we came up with that. And right now, we are retraining that again to provide a larger data set. But hopefully, once that's available, then we will have a synthetic data set. Again, that has to go through many steps of also evaluation, validation by annotators to make sure that it has the fidelity that we want. All right. Now, the last question that we had, hopefully not the last question, but one of the questions that we had was also, okay, we are collecting a lot of data. Each one of those modalities on their own can be helpful. For example, for measuring physical function or for measuring pain. But can we use all the modalities together in order to get a better picture of the patient acuity? And that is somehow expected, because if a patient is in a very acute stage, you would expect them not to be very mobile or even to be reflected in their facial expressions. So we took all the data that we have from different sources. We combined that with our clinical data, and based on that, we are also again doing the predictions for acuity, for delirium, for some of the outcomes. And it seems that in most cases, it's actually improving the results. Maybe not by a large margin, but still it's improving the results. So that's another interesting finding that we had. All right, so we talked about sensor data in ICU. We talked about physiological data. The next piece that I want to talk about is cognitive function. And cognitive function is very important, especially in older adults that are undergoing surgery. It has been shown that older adults, once they undergo surgery, there is a decrease in their sharp decline, in many cases, in their cognitive function right after surgery. We still don't know exactly why that happens. It might be because of the analgesics that are used in the operating room, or it might be because of some of the other agents that are used, but that happens. And it has been recommended by the American College of Surgeons that all the older adults that are undergoing surgery to actually have cognitive screening before. But remember what I was telling you about the nurses, they have a lot to do. Now, you add one more thing for them. Okay, also do the assessment for cognitive function. It takes time. One of the simple tests, for example, is the clock test that you might have seen. It's very simple. You tell the patient, all right, draw a clock from memory and set the hands to something like 10 after 3 or 10 after 2, something like that. Or copy a clock. There are two different versions. Do that. You would be surprised how much it can tell you in terms of all of these different cognitive functions that we have here. Like in terms of verbal understanding, memory, spatial knowledge, fine motor skills. For example, if you're missing a hook in one of the digits, it can tell you a lot. If the shape of the clock face is asymmetrical or it's not completely circular, we actually have shown that that can be associated with a certain condition and not another one. So it can tell you a lot, actually, but it takes time. Doing this test takes about 15 minutes if they want to go through all of these very fine errors and score the clock. And also, you have to be trained for them. So what do? Well, with my colleague, Dr. Catherine Price, who has been the clinical PI for this grant, we have been collecting digital clocks at the University of Florida, and this is actually the largest such clock data set, digital clock data set that has been collected. So we collect all of that data, and then we have been developing models using that data. And since we have the ground truth, which is also the associated cognitive function assessment in terms of some of the other standard cognitive function assessments, we have been able to develop those models. And we went through many different stages of developing the models. The one thing is that because scoring the clock takes a long time, we did not have many labeled clocks. We have, right now, actually, that number has to be closer to 30,000. You have 30,000 clocks. Again, labeling, annotation problem. So how do you deal with that? And here we decided to take a slightly different approach, which is semi-supervised learning. So we have been using different types of semi-supervised learning and self-supervised learning techniques in order to battle that issue. And here you can see some examples of the clocks that I was telling you. For example, that shows the increasing probability of having dementia or early dementia. And you can see the last one on the right, everything is almost messed up. But how do you score that digitally? Using a computer vision techniques. And again, we have developed some of those models, semi-supervised, self-supervised. And the nice thing about those, for example, in one of our work that we were using an RF VAE, is that it came up with all of these factors that you see here that are disentangled that can tell you what is the characteristics of those clocks that you see. And we were looking at control group versus early dementia group, early stages of dementia. And the one feature that was the top feature for the dementia group was that they tend to draw avocado-shaped clocks. So that's the main feature that you would see in somebody who is in the early stages of dementia. They don't draw it circular, they draw it as an avocado. And there are also other interesting features that we have seen in other conditions. For example, if you have working memory issues, you might tend to have small clocks. For different condition, you might draw large clocks in the corner. So each one of those different conditions, the patients exhibit a different set of features, which is very interesting. And some of those features had not been reported before in the literature. And the fact that the model comes up with those features is very exciting. I'm not going to go over this one, but we also looked at how some of the patient characteristics, such as education level, can also change the way that we are interpreting the results. And finally, in terms of also going beyond computer vision, sometimes you can get the cognitive function measures from vision, from the way that the patients are processing the information visually. Sometimes you can also get that from speech analysis. And this is not something new. A lot of other people have looked into this, but the work that we have done is just adding to the evidence that if you're looking at speech signals in dementia patients versus the control groups, it can give you hints about how the patient is doing in terms of their cognitive function. And more specifically, in this work, we were looking at the pauses. If they are pausing a lot between the sentences, and we were using a standard neuropsych assessment that is called story recall. So you tell them a story, and then you ask them, hey, can you recall this story? The amount of pauses that they have. And also we looked at also some of the frequency features, the MFCC features for this work. It can tell you a lot. We did not have many samples, so we did not go with more sophisticated approaches, but even though it was a small sample size, still it is in line with the literature that tells us, even just from speech, you can tell if somebody is in the early stages of dementia or not. So that can be helpful. And finally, we can do all of this in the clinical setting. When the patient is doing, when the patient is staying in the ICU, or if they have an operation and they are in the OR and post-OR. But what happens once they go home, especially older adults? And that has been an issue. We were talking to some of our colleagues. What happens to the patients who have the TKA replacement, the knee replacement arthroplasty surgery, and they go home? They said, well, they have one follow-up call and then they are visited. They can visit us 1 week later, and that's it. What happens in between? Can we track them? Can we monitor them? And we have been doing some work on that by collecting data from smartwatches automatically, for example, on their mobility, on their pain, mood, fatigue level, and also asking the patients how they are doing in terms of their gait aid usage, and so on. This is not so much technical in terms of machine learning, but it was interesting to us from the provider's perspective, because sometimes as computer scientists, engineers, we tend to like to have solutions and give them to providers, but usually it doesn't work that way. So for this one, we went to the providers and we asked them, how would you like information from patients to come to you such that you can see that in the electronic health record system? Because right now, if you open up Epic, you won't be able to see the information from your patient's smartwatch. We built that link and we asked the providers, what do you like to see? How would you like to see that? The way that you visualize the data, the information and the amount of information that you're providing also matters. So that's another interesting link that brings back the patient-generated health data back into the clinical setting, and it doesn't stay with the patient. Okay, and the last couple of things that I wanted to talk about is just to briefly show to you some of the educational AI tools that my students have been working on. For example, the top one that you see, one of my students has been working on developing environments for running AI models. And here you can also see how it works on reinforcement learning. All of these agents that you see are running in parallel, and you can automatically change the settings for the learning environment. Here he does that, the learning rate, the type of algorithm, whether it's SARSA or something else, the reinforcement learning models. You can run that entirely on your browser without any need to install any third-party library. Like you don't need to install PyTorch or anything. And this can be helpful in educational settings. If, for example, you're teaching AI to high school kids or to others who might not necessarily have all of the libraries already pre-installed. And it's completely visual, it's 3D environment, and it has a very good performance, surprisingly, that it runs just in the browser. And it also has a chat interface that you see here. And he's right now expanding that to include all of the lessons on different AI models for reinforcement learning and beyond. On the national stage, we also have been involved in medical AI education as part of our NIH Bridge to AI project. So about 2.5 years ago, 4 projects in the nation were awarded by NIH to work on developing the next generation AI-ready data sets. You have seen all of the work that we are doing is relying a lot on data, just like anyone else. Data is what we need. And we have been thinking a lot about this, that in critical care domain, we have something like MIMIC, which is a public data set that was developed by MGH, Massachusetts General Hospital. But it's data just from one institution. And there is no such data set that represents the entire US. So what do? We need that kind of diversity. We need different institutions. Because right now, if I develop my model here at UF, I bring it here to Johns Hopkins, it's not going to work that well. The performance is dropping. And we have seen that in our external validation. So how do we get that kind of data? And it's not easy. It's not like as one individual investigator in one university, I can do that. So as we are 12 PIs on this grant, but there are 20 institutions that we have teamed up together that we are developing these largest critical care data sets that hopefully we will release in about 1.5 years from now. And I think that would be a great resource for anyone in the community. It will have the waveforms, medical imaging data, clinical notes, EHR, and all of that. And along with that, we also have been developing a lot of medical AI educational tools that also will be made public, such as the Python notebooks that are based on the data that we are collecting that will be provided to the public. So that's another thing that we are doing, and hopefully at some point, all of that will be provided to the public. There are also 3 other projects, but in different areas. One of them is in the omics area, another one is on voice data from patients, which is very interesting. So hopefully all of that will be available soon. All right, so I talked about all of this, but what is the long-term vision here? I would say that the long-term vision, from my point of view, is to be able to use AI models in order to provide patient care that is more objective. So it's not subjective, it doesn't change. It is precise. It is granular. So we are looking into details because sometimes details matter. And it's also comprehensive. So we are looking at all the modalities that we have, all the data. We are thinking not just about the heart rate, the worst heart rate measurement of the day, but we are also thinking about how the patient is doing. I guess it's time for me to go. Bye, everyone.
Keep talking.
Yes.
Once in a while, we'll come back.
So,
You will very much AI.
yes. I realized that I have been talking for too much.
Yeah. No, no,
So I guess we want also the data to be comprehensive, the way that we have been talking about that. Not only data about patient itself, but also about their environment. What is going on in the ICU? Is it comfortable enough? They are getting enough sleep? Is there too many visitations? All of that is important, and all of that is going to be also important when you are developing the models. So I guess it's still trying to come up. My next slide, I think it is on challenges. So, but all of that is great, but still we have a lot of challenges. One of the things is that we have been focusing too much, guilty myself, my group, on predictions. Prediction is the first step. How do you go from prediction to action? And in healthcare world, it's not easy because, well, when you're developing a reinforcement learning model using some agents or some Atari game or simulated game, okay, you can replay that. You can have replays to make sure that works better. But what about healthcare? You cannot have replays of different types of interventions on the same patient. It's impossible. It's unethical. You cannot do that. How do you get that kind of data? How do you develop these kind of actual decision support systems or decision systems that can help you to provide interventions in a more intelligent way? And legally speaking, ethically speaking, that requires a lot of thought how we are going to do that. Prospective validation. Validation is another piece. We have been doing that in my group, but it's not easy to do that because it requires the real-time infrastructure. We had a 5-year grant from NIH to already build that. But what about some of the smaller institutions that might not happen? But still, it's important because without that, we cannot do anything. Data sharing, sure, I talked about bridge to AI. Federated learning is another thing that I think would be important in the healthcare domain. Interpretability, explainability, we talk about that all the time. We have all of these methods, but I still don't think that we are there yet. We cannot still explain the models very well, at least to different stakeholders. The explanations that a doctor would require compared to a nurse, it would be different. Compared to somebody who is debugging the model. All of those, the stakeholders, I think, need to be involved in the process. And sometimes as computer scientists, we love to come up with solutions and we have this very cool new method that we are developing, but is it really helpful? If I'm highlighting the time series of the physiological signal, does it tell them a lot? What else they would like to see? And that's the one piece that I think as somebody who was trained in computer science, I tend to think in quantitative way, not so much in qualitative ways. And sometimes we need to go back and work a lot with people who have been trained that way. And we have been doing that in our research. And it has been eye-opening that you can learn a lot. So they have been going out to the ICU, for example, just silently, just watching and observing how the workflow is arranged and what are some of the inefficiencies. And they come back and tell us a lot about what are some of the key problems. So I think that's also very important, making it more interdisciplinary. And the last piece is, again, the technical debt. I don't know how many of you have read that paper. It came out many years ago, I think 2014 or so, that yes, it's great. We are building AI models, back then ML models, but we love to do that. But it's not the main piece. We first need to have the system in place, the infrastructure in place. And the thing is that the whole academia is not set up to deal with that. We don't incentivize building infrastructure or systems per se as much as we would incentivize building models and getting another 2 or 3% performance increase many times from publication system all the way down. When something is just operational, it gets lower priority. But we need to build all of that, even if it takes 2 or 3 years, in order to build something that is more exciting on top of that. So how do we address that challenge? I don't know exactly, but that is something that we need to address that in order to be able to develop those systems that might have more of a transformative approach to healthcare. So that's all that I have. I know already the screen told me that I have been talking too much, but happy to take your questions.
But I feel like some of it maybe has extensions towards like early monitoring, especially with like domestic cases where like subtle changes over time are very hard for humans to pick up on, but maybe like there's more objective systems. Do you have any like insights or aspirations towards like projects that move in that direction?
Yes, you're absolutely right. I think that's a very good point that some of those work can have extensions in non-acute care setting for detecting delirium, declining cognitive functions. Many of our older adults, they live alone. So how do you notice that their cognitive function is really declining in subtle ways if nobody is living with them to notice that kind of change? And one way might be to use some technology. You can think about having technology that you're interacting with. Maybe it's just your phone, but the speed of the way that you're interacting with the phone, the way that you're giving speech commands, and then it realizes that over time you have more pause in between your sentences, between your words. It can detect some of those subtle changes over time. So I think that in the future we will have more of those embedded into our daily life to give us more sort of metrics about how we are doing, not just older adults, but this morning with Sanjeev, we were talking about also kids, how you can get some of those metrics about how they are developing in terms of their cognitive functions over time in daily life. And I kind of like that approach when the technology is receding back into the background. You don't see it, but it's there. And it is giving you some perspective on what is going on, more quantitative perspective, and can give you numbers that then you can take some actions upon that. But to your question, yes, definitely it is something that is possible. I think there will be a lot of work in that area. Yes.
So you talked about very nice talk in the sense that you gave us the big picture of what it takes to do real things that are close to translation. And so let's go back to one of the last things that you say, take action. Now, take action involves taking steps, sequential steps that are actually, if you're going to try to do it as things are happening, as you're predicting, that involves a whole different machine learning, which goes back to some of the old, I'm not saying rule-based systems, but you have to take steps, sequential processes. What's your thoughts on that and how do you address that?
You're absolutely right. I've been thinking about that. And I think that is a really challenging problem because, as you say, this is a sequential decision problem.
Yes.
So in the old days, we had like Markov models and Markovian, just go back one state, but healthcare doesn't work like that. It's not one state that you go back. Even with reinforcement learning, the classical reinforcement learning is not going to work here. And I think that you're right. We would need a new brand of machine learning models. And I think the key, might be also incorporating knowledge into those models. So classical RL, if you think about that, it's all about the mathematical formulation of what is happening, but you don't have the external knowledge. But look, we have all the medical textbooks, we have all the PubMed at our fingertips. If you incorporate that, and if you incorporate what we have learned from all the patients that we have seen before, can we tell you what is the most probable next step? Now, possibly we can develop something like that even today, but I think the most challenging part is evaluation. That anytime I think about that, again, it's not a Atari game that you simulate that. Yeah. So for understanding if you take action A versus action B, this would be the outcome. So I can teach my model, I can supervise it, I can give the signal, but in real world, you cannot do that to a patient. And we are not there yet in terms of, I think, the capabilities to have fully simulated systems that maybe if we had that, that could simulate everything to the very last detail, then you would be able to simulate an entire patient. Maybe 1,000 years from now, I don't know. But that's the problem, I think, is in the evaluation. How do I evaluate my model that is robust? Because if it's not robust, nobody's going to be
So something, I mean, what you're saying also, something in the sense creating hypothesis of that,
Yes.
maybe a hypothesis of what the steps should be and the bridges we get hard.
So the way that we have been tackling that so far in a very limited way has been, we are doing a lot of silent deployments. So we deployed the model actually in the clinical setting, but we don't show it to the clinicians because even just showing the results to the clinicians is going to prime them. And then you're responsible actually for the actions that happens to the patient later because you have primed the clinicians. This is what AI thinks. Now they are thinking, okay, maybe I should do this. So unless you're super certain, it's difficult. So we have been doing a lot of silent deployment that we track our outcomes that the model is predicting and also the actual outcomes. And then you can look at the trajectory. What are some of the possible actions that could have maybe, based on the evidence, changed your trajectory? That we can do, but it's not exactly like real world evaluation. Yes.
So what do you think about treatment discovery through RL? Like you just mentioned that how you cannot essentially treat treat this as in a RE setting, but there's a lot of work to make simulators using the mimic data set for the sepsis treatment. Now, sepsis as a disease does not have a traditional treatment approach in medicine, whereas I could train a PPO or a DPO standard RL algorithm by essentially making a replay buffer and having a treatment policy. Now, there is no work on evaluating it, like you correctly pointed out, but isn't that
So there has been some work evaluating, but again, those are very limited approaches. As you say, you build a simulator on top of Mimic, for example, for sepsis. And I think the very first paper came out, not mistaken, in 2018 or so, that was looking into RL for sepsis. Problem is that it's all based on the data that you have, which is the data for the clinicians taking specific steps, but not other ones. So you have action A, but you don't have the results on action B. And that's where I think that problem comes into the play that what are some of the alternatives? Because when you're simulating games, you try to kind of have a very nice diversity, but the reality is that these days we have clinical guidelines. All the doctors more or less are working based on those guidelines, which is a great thing actually. But if we change one of those steps, it takes a long time. Usually it is based on consensus guidelines, the doctors coming together in many conferences, and then they say, you know what, we need to change this thing. If you want to do that in a more facilitated manner that is done by AI, we need evidence. And part that I'm still thinking about it, where do we get that? Not just action A that you have in Mimic, but the action B that did not have. We don't have that for full simulation.
This looks like we have to get people who do reinforcement learning to work with people who do counterfactual reasoning. Then you can figure out what is. Another question, last question. No further questions, we'll thank you. Okay, again.
Thank you.